Welcome back to the deep dive. Today, we are shifting gears. We aren't just exploring a topic for the joy of learning. We are entering the war room.
That's a good way to put it.
I want you to visualize where you are right now. You are not in your car. You are not on a jog. You are sitting in a stiff wooden chair. The air conditioning is humming a bit too loudly. Your palms are sweating. And across the table sits a panel of senior professors.
The Viva Voce.
Exactly. You are in the middle of your MD anesthesiology postgraduate exams, and specifically, we are simulating the very high standards of the Gujarat University exams.
That sets the tone perfectly. Today isn't about casual reading. It is about precision. It's about survival.
And patient safety.
And most importantly, it is about patient safety in the absolute most vulnerable population we treat.
We have a massive stack of materials here. We've got the heavy hitters, Miller's Anesthesia, Morgan and Mikhail, Yao and Artuzio, the Oxford handbooks, and some very specific protocol guides on pediatric neuroanesthesia.
A mountain of paper.
A mountain. And our mission is to synthesize all of those thousands of pages into a comprehensive, razor-sharp audio guide on what we are calling the Neuro Triad of pediatric anesthesia.
The Neuro Triad. I like that. Intracranial hemorrhage, hydrocephalus, and Myelomeningocele.
The big three.
If you are sitting for your MD exams, you will see these. There is no escaping them.
No way around it.
None. You might get a long question on myelomeningocele repair. You might get a short note on the pathophysiology of raised intracranial pressure. Or in the Viva, you might be handed an X-ray of a skull and asked to explain the beaten copper appearance.
So consider this your high-stakes coaching session, and I am joined, as always, by our resident expert. For today's session, you are stepping into the role of that senior MD faculty examiner. You are the one asking the tough questions.
I am, and I'm going to be stern because the examiners will be stern. In neuroanesthesia, specifically pediatric neuroanesthesia, the margin for error is effectively zero. A mistake here isn't just a bad day or a longer hospital stay. It is a catastrophic, permanent brain injury. So throughout this hour, I will be pointing out exactly what the examiners want to hear, what the gold standard answers are from Miller, and crucially, identifying the fail points.
Fail points. I like that concept. The specific phrases or errors that, if you say them, essentially end the exam right there.
Exactly. There are certain safety thresholds where if you cross them, an examiner cannot pass you in good conscience. We will flag those clearly.
Okay, let's start with Part A, the introduction and exam framing. Why is this topic, this triad of ICH, hydrocephalus, and myelomeningocele, such a favorite for examiners? Why does it appear year after year?
It's a perennial favorite because it's the perfect storm. It's not just one thing. It tests three distinct domains simultaneously.
Okay, what are?
First, it tests your pediatrics knowledge, the physiology, the anatomy, the pharmacology of the neonate, which is completely distinct from the adult. Second, it tests your neurology, the physics of the brain, the pressure dynamics. And third, it tests crisis management. These are often anesthetic emergencies. You aren't just sitting there charting, you are actively resuscitating.
And from the sources we have, specifically Miller's Anesthesia, there is a lot of emphasis on that first point. Neonates are not just small adults.
That is the fundamental rule. It's rule number one. If you don't get that, you can't proceed. You have to understand that a neonate with an open fontanelle and open sutures reacts differently to pressure than an older child with a closed, rigid skull.
Okay.
Their cardiac output is rate-dependent. Their autoregulation curves are different. If you treat a neonate like a small 30-year-old, you will cause harm. It's that simple.
But despite the differences in pathology, I mean, whether it's blood in the case of ICH, fluid in hydrocephalus, or a structural defect in myelomeningocele, there is a common thread binding all three for the purpose of the exam, isn't there?
There is. The common enemy.
Yeah.
The central villain of the story. Raised intracranial pressure, or ICP. Whether you are dealing with a bleed, too much fluid, or a structural defect that's about to be closed, your primary job as the anesthetist is to manage the pressure cooking inside that skull.
So even though the surgical solution is different for each one,
Completely different.
the anesthetic battleground is the same?
Precisely. The examiner wants to see that you understand the unifying pathophysiology. If you can explain how you protect the brain from secondary injury caused by raised ICP, you pass. If you treat it like a routine inguinal hernia, you fail.
Let's talk about the exam patterns quickly before we dive into the clinical meat. What are we looking at here? What should you expect?
Okay, so in a written paper, you will often see pathophysiology of raised ICP as a standalone short note. That is bread and butter. You need to be able to reproduce the graphs and the math without thinking.
Just rote memory.
It has to be. For long questions, 10 to 20 marks, you'll get a scenario. Describe the anesthetic management of a 3-month-old for ventriculoperitoneal shunt insertion.
A VP shunt, right.
Or anesthetic considerations for myelomeningocele repair in a neonate. Very classic questions.
And the Viva. That's where the pressure really ramps up. That's the real test.
The Viva is where they try to trip you up on clinical judgment. They might show you an X-ray with that beaten copper appearance we mentioned, or they might ask you a very specific question like, "Doctor, you are tunneling the shunt and the heart rate suddenly drops to 50. What do you do?"
They want to see how you think on your feet.
They want to see if you panic or if you know the physiology. If you can connect the bradycardia to the vagal stimulation of the tunneling and have a plan.
Okay, let's unpack this. We are going to take these one by one, starting with the first part of the triad, intracranial hemorrhage or ICH.
Right. Let's start with the bleed.
Part B, intracranial hemorrhage. First off, for the exam, we need a crisp professional definition. How are we defining ICH?
Simply put, it is bleeding within the intracranial vault. That's the basic definition. But for the exam, you can't stop there.
You need more.
You need to immediately differentiate between spontaneous and traumatic causes, and then you must break down the anatomical types. This classification is absolutely essential knowledge. You cannot stumble here.
Okay, let's break down the types, specifically focusing on the pediatric population. What is the examiner looking for?
First, intraventricular hemorrhage, or IVH. This is the domain of the preterm neonate. It's almost exclusively their pathology.
And if you mention IVH, what's the buzzword you have to use?
You must immediately mention the germinal matrix. If you talk about IVH without saying germinal matrix, you've missed the entire point of the pathophysiology.
The germinal matrix, I saw that in the pathology notes and in the Robbins text. Why is that structure so important, and what is it?
So the germinal matrix is this highly vascularized, metabolically active area in the developing brain of a preterm infant. It's where the neurons and glial cells are born before they migrate out to form the cortex.
A neuronursery, basically.
A perfect analogy. But structurally, it is incredibly fragile. The vessels in it are immature. They lack the muscular support, the collagen that mature vessels have. So they are very, very prone to rupture.
And what makes them rupture?
Fluctuations in blood pressure or cerebral blood flow. So if a preterm baby has a swing in blood pressure, maybe they get agitated, or we intubate them roughly, or they have a hypotensive episode followed by resuscitation.
Those vessels just pop.
They pop. And because of where the matrix sits right next to the ventricles, the blood spills directly into the lateral ventricles. That is IVH. It is a specific pathology of prematurity.
Okay, so IVH is preterm, fragile vessels, germinal matrix. Got it. Moving to the traumatic side, what about epidural hematoma? EDH.
EDH. This is usually traumatic.
Yeah.
The classic teaching, and you must say this in the exam, is the rupture of the middle meningeal artery.
An arterial bleed.
Yes, which means it's high pressure and it can expand very, very quickly.
And then this is associated with the famous lucid interval, right?
Yes, the lucid interval. But be careful here. There's nuance for pediatrics. In infants, the skull is more deformable. They might not have a skull fracture, but can still tear a vessel due to the bone bending. In older children, it's almost always associated with a temporal bone fracture.
So the presentation is different based on age.
Slightly. But the classic presentation is a blow to the head, a period where they seem fine, that's the lucid interval, and then a rapid catastrophic deterioration as the hematoma expands, strips the dura off the bone, and compresses the brain.
It's deceptive. They walk in talking and can be dead an hour later.
That is the nightmare scenario. It is a true neurosurgical emergency.
Okay. Moving inward. Subdural hematoma, SDH.
SDH is usually venous. It's the tearing of the bridging veins that cross on the surface of the cortex to the big venous sinuses.
And why do those tear?
In pediatrics, sadly, you have to keep a high index of suspicion for non-accidental injury-shaken baby syndrome.
So the acceleration-deceleration forces.
Exactly. The brain moves inside the skull, but the sinuses are fixed to the dura. The veins bridging that gap stretch and tear. Because it's venous, the bleeding is slower, so the presentation can be more subacute compared to an epidural bleed.
Okay. And finally, subarachnoid hemorrhage, SAH.
This is usually arterial, often a ruptured aneurysm or an arteriovenous malformation, an AVM.
And the key phrase for the Viva here.
Thunderclap headache. Sudden, severe, the worst headache of their life. For an older child who can talk, that's the classic description.
So we have the types. IVH for preterms, EDH is arterial and fast, SDH is venous and slower, SAH is often from an aneurysm.
A perfect summary.
Now let's get to the exam gold, the pathophysiology. You mentioned the Monro-Kellie doctrine earlier. I feel like this is something every anesthetist nods at, but can they really explain it under pressure?
They better be able to. It is the absolute foundation of neuroanesthesia. You have to explain it clearly. Imagine the skull as a rigid box, a fixed volume.
In older children, anyway.
In older children and adults, yes. Inside, you have three things. Brain parenchyma, which is about 80%, blood about 10%, and cerebrospinal fluid, or CSF, the last 10%.
Okay, 80-10.
The doctrine states that the sum of these volumes is constant. So if you add a fourth element, a hematoma, a tumor, edema, something else has to leave the box or the pressure will skyrocket.
And since the brain tissue can't really leave without causing, herniation and death.
Exactly. The brain is the last thing you want to leave. So initially, you have compensation.
What leaves first?
CSF. It's the most easily displaced. It gets shunted down into the spinal canal. After that, venous blood can be squeezed out of the cerebral sinuses. That keeps the pressure down for a little while.
So that's the buffer system.
That is your buffer. But once you exhaust those mechanisms, once the buffer is gone, you hit the knee of the compliance curve.
The knee of the curve.
Yes. Picture the graph. Initially, volume goes up, but pressure stays flat. That's compliance. But then you hit a point, the knee, and after that, even a tiny increase in volume causes a massive vertical spike in intracranial pressure.
And that's when the patient crashes.
That's when they crash. And that brings us to the most important equation you will write down in your exam paper. Cerebral perfusion pressure.
CPP. Let's derive it. I want to hear you say it.
CPP equals MAP minus ICP, mean arterial pressure minus intracranial pressure.
Sometimes you see central venous pressure, CVP, in that equation.
Correct. Technically, it is MAP minus the downstream pressure, which is usually ICP, but if CVP is massively elevated, say from a tension pneumothorax, it could be the limiting factor. But for these pathologies, assume ICP is the enemy. So CPP equals MAP ICP.
And why does this matter so much?
Because as an anesthetist, you cannot fix the primary injury. You cannot unbleed the brain. Your entire job, your whole reason for being in that room is preventing secondary brain injury.
And secondary injury is caused by ischemia.
Ischemia, exactly. Look at the equation. If ICP goes up because of the bleed and you let the MEP drop, say you give a big careless dose of Propofol and the blood pressure tanks, what happens to CPP?
It crashes. It goes to zero or even negative.
It crashes. The pressure pushing blood into the brain drops below the pressure pushing back. The brain starves. The neurons die. You've caused secondary brain injury. Your goal is simple. Maintain MAP, lower ICP. That's the game.
Before we get to management, what are the clinical signs? If I'm seeing a neonate with ICH, what am I looking for?
In a neonate with open fontanelles, the head can actually expand as a compensatory mechanism. So look for a bulging, tense anterior fontanelle. It shouldn't be soft and pulse it a little, feel hard.
Okay.
You'll see increasing head circumference on the daily charts. And the sunset sign. You have to mention that.
Describe the sunset sign for the listener. What does it look like?
It's where the eyes are driven downward due to pressure on the midbrain structures, specifically the protectal area, which controls upward gaze. You see the white sclera above the iris, like a setting sun dipping below the horizon. It's an ominous sign.
And in an older child with a closed skull?
You won't see head expansion. You'll see the classic signs of raised ICP, headache, vomiting, often projectile and without nausea, and eventually altered sensorium and the Cushing reflex.
The Cushing reflex is a late sign, right? That means things are going very, very badly.
It is a terminal sign. It's a sign of impending or active brainstem herniation. It's a triad. Hypertension, bradycardia, and irregular respiration.
Let's break that down. Why does that happen physiologically?
It's a last-ditch effort by the brain to save itself. The ICP is so high that it's crushing the arterioles in the brainstem. The brainstem vasomotor center senses this profound ischemia.
So it panics.
It panics. It triggers a massive sympathetic surge to drive up the systemic blood pressure. Hence, the hypertension is trying to force blood into the brain at any cost to overcome the ICP.
And the bradycardia.
That's a reflex. The baroreceptors in the carotid arteries and aortic arch sense this crazy high systemic pressure, and they fire signals to the vagus nerve to slow the heart down. So you get this paradoxical combination of hypertension and bradycardia.
Okay, let's talk management. This is the very high yield section. I am the anesthetist. I have a child with massive bleed, raised ICP, coming in for an emergency craniotomy. What is my game plan? What's the mantra?
Your mantra is neurological protection. Everything you do flows from that.
Yeah.
First, airway. This is an emergency. They likely have a full stomach because trauma happens after lunch, or the raised ICP has caused gastric stasis.
So rapid sequence induction.
You must do a rapid sequence induction, or RSI. There's no debate.
But RSI involves laryngoscopy, which causes a huge sympathetic surge, right? That spikes the heart rate and BP.
Exactly. And we just discussed we want to maintain MAP, but a sudden jagged spike can increase cerebral blood volume, worsen the bleed, or spike the ICP even higher. So you have to blunt that response.
How do you do that?
You need to use lidocaine, about 1.5 milligrams per kilogram, a minute or two before intubation. Or a small dose of an opioid like fentanyl or remifentanil. This obtuns that powerful laryngeal reflex.
And you can't let them cough?
You cannot let them cough or buck on the tube. Coughing raises intrathoracic pressure, which raises CVP, which impedes venous drainage from the head and raises ICP. A smooth, deep intubation is critical.
What about induction agents? This is always a debate. Which one do you reach for?
Propofol or thiopentone. These are your best friends here. They are potent cerebral vasoconstrictors.
So they shrink the brain, in a sense.
They do. They reduce the cerebral metabolic rate of oxygen consumption, the CMRO2. And because flow is coupled to metabolism, this triggers a reduction in cerebral blood flow, or CBF. Less blood flow means less cerebral blood volume, which lowers ICP.
So they put the brain to sleep and shrink the blood volume in the skull.
Precisely. They buy you space in that rigid box.
And ketamine. There's always a debate about ketamine in neuroanesthesia. What's the exam answer?
Right. Miller discusses this extensively. Traditionally, ketamine was absolutely contraindicated. The old studies suggested it was a cerebral vasodilator that increased CBF and ICP.
But that's changed a bit.
The thinking has evolved. More recent evidence suggests that if ventilation is controlled to maintain normocapnia, and especially if a GABA agonist like Propofol or a benzodiazepine is used concurrently, ketamine might be safe or even beneficial. However, you are in an exam.
Right. This isn't a research seminar. Stick to the script.
For the exam, play it safe. State that it is traditionally avoided in raised ICP unless the patient is hemodynamically unstable. If the child is crashing from blood loss and is hypotensive, ketamine is a fantastic choice because it will maintain their blood pressure and thus their CPP.
So hypotensive and brain injured, ketamine is okay. Normal tensive and brain injured, use propofol or theo.
That is the safe, nuanced answer that will pass.
Okay, stick to the safe answer. Now fluids. This is a huge trap, isn't it?
A massive trap.
Yeah.
And it's so easy to fall into. Do not use dextrose-containing fluids. Do not use hypotonic fluids.
Why not? I mean, kids get hypoglycemic easily, don't they? We are always taught to watch their blood sugar in pediatrics.
They do, and you absolutely should monitor their glucose with finger prick tests. But routine glucose infusion in a brain-injured child is dangerous.
Explain why.
If a part of the brain is ischemic, it can't use oxygen, so it switches to anaerobic metabolism. If you provide a huge load of glucose, that anaerobic glycolysis produces a massive amount of lactic acid.
And acid is bad for neurons.
Lactic acid causes intracellular acidosis and destroys neurons. You're essentially feeding the injury, so hyperglycemia plus ischemia equals dead neurons.
So what fluid do we use?
Normal saline, 0.9% saline. It is isotonic, maybe slightly hypertonic, and it helps maintain serum osmolality, which prevents free water from moving into the brain and causing cerebral edema.
Okay. Ventilatory goals.
Normocapnia. Your target is a PaCO2 of 35 to 40 millimeters of mercury.
I thought we were supposed to hyperventilate to blow off CO2 and shrink the brain. That's what I remember from medical school.
That is the old dogma, and examiners love to see if you know the update on this. Mailer is very clear on this. Aggressive hyperventilation, say to a PaCO2 of 25-30, causes profound cerebral vasoconstriction.
So it does lower ICP?
Yes, it lowers ICP, but it can also cause or worsen cerebral ischemia because you are choking off blood flow too much. It's a double-edged sword.
So when do we use it? Is there ever a time?
You only use it as a temporizing rescue measure. If the patient is actively herniating on the table, a pupil blows, you see the Cushing response, while the surgeon is trying to open the skull, then you can hyperventilate to buy a few minutes.
It's a bridge to surgery?
It's a bridge to decompression. It buys you 10, maybe 20 minutes before the effect wears off. It is not a routine strategy. For routine maintenance, aim for normocapnia.
Got it. Normocapnia is the goal. Hyperventilation is the emergency parachute.
Precisely. You couldn't have said it better.
Okay, let's move to the second part of our triad. That was a great deep dive on ICH. Let's talk about part C, hydrocephalus.
Hydrocephalus. All right. Again, start with the definition. For the exam, say, it is a dynamic imbalance between cerebrospinal fluid production and absorption, leading to enlarged ventricles and eventually raised intracranial pressure.
And the classification, this feels like classic Viva fodder.
Absolutely. It's communicating versus non-communicating, which is also called obstructive.
What's the difference?
Communicating means all the ventricles are in communication with each other and the subarachnoid space. The CSF can get out of the ventricular system, but it isn't being absorbed properly by the arachnoid villi.
And what would cause that?
Maybe post-meningitis scarring that clogs up the villi, or blood from a previous hemorrhage gumming up the works.
And non-communicating.
That means there's a physical blockage somewhere with the ventricular system. The classic example is aqueductal stenosis, where the narrow aqueduct of Sylvius between the third and fourth ventricles is blocked, or a tumor in the fourth ventricle blocking the outflow.
Pathophysiology here. We talked about the box and the compliance curve. How is hydrocephalus different from a bleed?
Time. The main difference is time. A big bleed is an acute event. Hydrocephalus, particularly congenital hydrocephalus, can be a chronic, insidious process.
Right.
The pathophysiology centers on that compliance curve we mentioned, but over weeks or months. In an infant with open sutures and a soft fontanelle, the skull can actually expand to accommodate the extra fluid.
So the head just gets bigger.
The head gets bigger. This keeps the ICP normal or only slightly elevated for a long time. They are compensating. But eventually, the sutures stretch to their absolute limit.
So these kids might look okay, relatively speaking, but they are ticking time bombs.
Correct. They have zero intracranial reserve. They are living right on the edge of that cliff on the knee of the compliance curve. The slightest thing, a cough, a cry, an induction agent, can push them over the edge into catastrophic ICP elevation.
What are the clinical features we need to list for the exam?
We mentioned the bulging fontanelle and sunset sign, which you see here as well. In older children, you'll see papilledema on fundoscopy. And on physical exam, percussion of the skull might elicit a cracked pot sound.
Mace-Wynn sign.
Yes, Mace-Wynn sign. It sounds hollow, like a cracked pot, because of the dilated ventricles and the separated sutures.
And on a skull x-ray, what's the buzzword?
Beaten copper or beaten silver appearance. You have to say this. It's caused by the gyri of the brain being pressed so hard against the inner table of the skull for so long that they actually leave indentations in the bone. It looks like hammered metal on the x-ray.
That is a great visual for the exam.
Now, management. The child is scheduled for a VP shunt, a ventriculoperitoneal shunt. It sounds like a simple procedure, but what are the anesthetic risks?
It is deceptively complex from an anesthetic standpoint. The induction is the most critical phase. You have a child with known or suspected high ICP, so you're thinking you need a smooth induction, probably an RSI.
Right.
But here's the trap. The airway might be incredibly difficult.
Why?
If the child is syndromic, they may have other airway anomalies. But even if not, the sheer size and weight of the head in chronic hydrocephalus can make positioning for intubation a nightmare.
So the head is massive. How does that affect intubation? The occiput is huge. If you lay them flat on the table, their neck is forced into flexion. The chin goes to the chest, and that completely closes off your view of the larynx.
So what's the solution?
You need to put a donut ring, or, more commonly, several folded towels under the shoulders and back. You need to create a ramp to lift the chest and align the oral, pharyngeal, and laryngeal axis. You have to bring the chest up to the level of the head.
Okay, now the surgery starts. The surgeon is tunneling the shunt catheter from the head down the neck to the abdomen.
This is the tunneling phase. I cannot stress this enough for the exam. This is an intensely painful and stimulating part of the surgery.
It sounds brutal.
The surgeon is jamming a long metal rod subcutaneously across the chest and neck. If your anesthesia is too light, the child will move, cough, or buck.
And if they buck, venous pressure rises, ICP rises.
And the brain can physically bulge out of the burr hole the surgeon just made in the skull. It's an absolute disaster.
So you have to anticipate the tunneling.
You have to communicate with the surgeon. Ask them, are you about to tunnel? And right before they do, you deepen the anesthetic with a bolus of opioids or Propofol. You have to stay one step ahead.
There is another danger during the connection of the shunt sudden decompression.
Yeah.
What's that?
Yes. So the surgeon has the ventricular catheter in place, and they connect it to the shunt system. If they let the CSF drain out too quickly, the ventricles can collapse rapidly.
Then that's a problem.
It's a huge problem. The brain pulls away from the dura. This can stretch and tear those bridging veins we talked about earlier.
Causing a subdural hematoma?
Exactly. You've iatrogenically caused a subdural hematoma. You cured the hydrocephalus, but caused a life-threatening bleed. So the release of CSF must be slow and controlled.
What about post-op? What are the main concerns?
Apnea, especially in former preterms or children with Chiari malformations. The sudden change in intracranial pressure and brainstem dynamics can blunt their respiratory drive. They need to be monitored very closely in the recovery room, or PICU.
Okay, that's a great overview of hydrocephalus. Moving on to Part D, Myelomeningocele. This is the third leg of the triad.
Myelomeningocele, MMC. This is a type of neural tube defect. Embryologically, it's a failure of the neural tube to close at the caudal, or bottom, end. This happens very early, around the 4th week of gestation.
And the definition is key here. You have to differentiate it from a meningocele.
You must. An examiner will ask this. A meningocele is a protrusion of the meninges and CSF through the defect in the spine. The spinal cord itself is in the normal position.
So it's a fluid-filled sac.
Right. But a myelomeningocele, which is much more common and severe, contains meninges, CSF, and neural elements, the spinal cord itself, or nerve roots protruding into the sac.
And that means?
That implies a significant neurological deficit below the level of the lesion: paraplegia, loss of sensation, bowel and bladder dysfunction.
And there is a crucial association we need to mention, the Arnold-Chiari II malformation.
Yes, you must mention Chiari II. Almost all, 90 to 100% of children with myelomeningocele have a Chiari II malformation.
And what is that exactly?
It is the downward displacement of the cerebellar vermis and the brainstem through the foramen magnum into the cervical spinal canal.
So the back of the brain is being squeezed down into the neck. What does that mean for the anesthetist?
It means the brainstem is crowded and under pressure. These children are prone to central apnea, stridor due to vocal cord palsy from stretching of the vagus nerve, and swallowing difficulties.
And it also causes hydrocephalus.
It's the primary cause of the hydrocephalus seen in these patients. That herniated tissue blocks the outflow of CSF from the fourth ventricle. So you have a triad within a triad: MMC, Chiari II, and hydrocephalus.
Okay. Let's talk about the specific management of the MMC repair. There is one word that if you forget it in the exam, you fail, period.
Latex.
Tell us about the latex allergy. This feels like a very specific, high-stakes board question.
It is. It's a classic pass-fail point. For reasons that aren't perfectly understood, these children are sensitized to latex protein very early in life. It might be in utero exposure, or more likely, from repeated exposure to latex catheters and gloves during their early care.
So the incidence is high?
The incidence of anaphylaxis to latex is incredibly high. Some studies say up to 70% of this patient population is sensitized.
So for the exam, what's the rule?
The rule is, assume every patient with a neural tube defect has a life-threatening latex allergy until proven otherwise. Your entire setup must be latex-free.
What does that mean, practically?
No latex gloves, obviously. No latex tourniquets. You have to check the bungs on your drug vials, as some are made of latex. Check your syringe plungers. And if you say, I would insert a standard Foley catheter, you have just failed the station, because most standard Foleys are latex.
Got it. Latex-free is non-negotiable. Now, preoperative management. We have a neonate in the NICU with this open sac on their back. How do we position them?
You cannot lay them supine, ever. You will rupture the sac, leak CSF, and cause meningitis. They must be kept prone or in a lateral position at all times.
That makes intubation interesting.
It does. It's one of the key challenges. You have two main choices. Either you intubate the baby in a lateral position, which takes a lot of skill and practice, or you can attempt a supine intubation, but you must protect the sac. You build a donut ring out of rolled towels or foam and place it around the sac. The baby then lies supine, but the sac itself floats safely inside the hole of the donut without any pressure on it.
And temperature control. This is a neonate with a huge open wound.
Critical. Absolute critical. These babies have a massive surface area for heat and fluid loss from that open defect. They are neonates, so they have a large surface area to mass ratio to begin with. You need aggressive warming.
What does that involve?
The operating room should be pre-warmed to a high temperature. You need a forced air warming blanket, like a bear hugger, a fluid warmer for all ID fluids and blood products, and you should use warmed, humidified, inspired gases. Hypothermia in these neonates is a killer.
Intraoperative positioning for the surgery itself is prone.
Yes. And prone positioning in a neonate comes with its own set of risks. You must place them on padded bolsters or rolls that support the chest and pelvis, leaving the abdomen completely free and hanging.
Why is the free abdomen so important?
Two reasons. First, if you compress the abdomen, you push the diaphragm up into the chest, which restricts lung movement and makes ventilation very difficult.
Okay.
But more importantly, you compress the inferior vena cava. This increases intra-abdominal pressure, which backs up blood in the epidural venous plexus in the spine.
Which means more bleeding at the surgical site because the veins are all engorged.
Exactly. You've created a bloody surgical field, which makes the surgeon's job harder and increases blood loss. And blood loss in these surgeries can be deceptive.
How so?
It seeps into the drapes, onto the floor. It doesn't collect in a neat suction bottle. You have to weigh the sponges carefully. In a 3-kilogram neonate, the total blood volume is only about 240 to 270 milliliters.
That's less than a can of soda.
Exactly. Losing 30 or 40 milliliter is a major hemorrhage for that baby. It's more than 10% of their entire blood volume.
So we need to be vigilant with fluids and have blood ready.
You need excellent IV access, preferably 2 lines. Miller suggests starting with 10-20 milligram boluses of isotonic crystalloid for initial losses. But you must have cross-matched blood in the room and ready to go. If losses exceed 10-15% of their estimated blood volume, you should be transfusing.
Let's move to Part E, integration. We have covered the 3 separate entities, but the examiner wants to see synthesis. How do we link them all together?
The link is what I call the pop-off valve concept. It brings it all together.
Explain that.
Think about the child with an open myelomeningocele. That open sac often leaks CSF. It's a pathological state, but it's also acting as a pressure release valve for the brain.
So it's preventing the hydrocephalus from getting worse.
It's keeping the ICP in check. Now, what happens the moment the neurosurgeon closes that defect on the back?
You've closed the pop-off valve?
You've closed the pop-off valve. The CSF has nowhere to go. The pressure starts to build up immediately.
So ICP starts rising intraoperatively or immediately post-op.
Immediately. That is why hydrocephalus often appears or worsens dramatically right after MMC repair. You have to anticipate it.
And ICH acts as a mass effect, adding volume. Hydrocephalus is a volume overload from within. And MMC repair leads to a sudden retention of volume.
Exactly. You see the common theme. In all 3 scenarios, you, the anesthetist, are the guardian of the CPP. You are constantly balancing MAP against ICP, trying to keep the brain perfused and safe.
Comparison tables are great for the written exam. How would you compare ICH versus hydrocephalus in a quick table format?
Okay, for the exam, column 1, ICH, column 2, hydrocephalus, row 1, onset, ICH is acute, sudden. Hydrocephalus is often subacute or chronic. Row 2, compliance. In acute ICH, the brain is tight immediately. There's no time for compensation. In chronic hydrocephalus, the skull has expanded, some compensation has occurred, but they are near the edge of the cliff.
And hydrocephalus versus MMC.
Row 1, relationship. Hydrocephalus is often the consequence of MMC due to the Chiari II malformation.
So one causes the other.
Correct. Row 2, added complexity. MMC has the added complexity of the open wound, the difficult prone positioning, the high risk of heat loss, and the absolute fail point of the latex allergy. Hydrocephalus management doesn't usually involve those specific issues.
Part F, exam integration. Let's hit the Viva traps. These are the questions designed to make you fail. We already mentioned latex. What about succinylcholine?
This is a classic trap. The examiner will lean forward and say, "Doctor, this is a newborn for myelomeningocele repair. Can you use succinylcholine for intubation?"
It's a trick question because of the paraplegia, right? We're all taught that denervation causes upregulation of acetylcholine receptors, which leads to life-threatening hyperkalemia if you give cyclimics.
Correct. However, the nuance they're testing is the timing. In the neonate, in the first 24 to 48 hours of life, that receptor upregulation hasn't fully happened yet, so succinylcholine is technically safe to use.
What?
But in the older child with the same condition, coming back for a shunt revision or a bladder surgery, it is absolutely contraindicated. The risk of cardiac arrest from hyperkalemia is real.
So what is the safe answer for the Viva?
The safe answer is to show the nuance, but choose the safer path. You say, while it may be safe in the immediate neonatal period before receptor upregulation occurs, my standard practice would be to avoid succinylcholine entirely in this patient population due to the known risk of hyperkalemia. I would use rocuronium instead to ensure patient safety.
Perfect. Shows knowledge, prioritizes safety. Viva Trap 3, fluid management.
We touched on this. The examiner will ask, what maintenance fluid will you use for this neonate? If you reflexively say, dextrose normal saline or D5 quarter normal, because it's a kid, you lose marks.
Stick to isotonic, normal saline, or another balanced salt solution.
And you state your reasoning. I would use an isotonic, non-glucose-containing fluid like normal saline to avoid iatrogenic hyperglycemia, which is known to worsen secondary ischemic brain injury. I will monitor blood glucose separately and treat hypoglycemia, specifically if it occurs.
Viva Trap 4. The airway and hydrocephalus.
The trap is assuming the head is just big. It's not just big, it's heavy, it's unstable. And if they have an associated Chiari II malformation, extending the neck to get a view might actually compress the brainstem at the foramen magnum.
So how do you answer that?
You say, I recognize this is a potentially difficult airway due to the large, heavy head and risk of neck instability. I will ensure proper positioning with a shoulder roll to achieve a neutral sniffing position, have a range of blade sizes and smaller ETTs available, and have a difficult airway cart immediately accessible. I will use gentle manipulation of the head and neck.
Let's talk about diagrams. In a written paper, drawing a quick, simple diagram saves time and scores a lot of marks. What should students be prepared to draw?
First, the CSF pathway. It's easy marks, just draw a simple schematic. Chordoid plexus, lateral ventricle, foramen of Monro, the third ventricle, aqueduct of Sylvius, Mentesis fourth, ventricle foramen of Luchka, and Magendie subarachnoid space. It shows, the basic anatomy.
What about for ICP?
Draw the ICP waveform. Just sketch the 3 peaks, P1, P2, P3. Then label them. Say that normally P1, the percussion wave, is the tallest. Then draw a pathological waveform next to it, where P2, the tidal wave, is taller than P1, and state that this indicates poor intracranial compliance. That is a sophisticated answer that will impress examiners.
And for myelomeningocele?
A simple cross-section of the spine. Draw a normal one with the cord inside the vertebral canal, then draw the MMC next to it, showing the splayed-out cord elements on the surface of the sac. It's a powerful visual.
We are coming to the end of our hour. This has been incredibly dense. Let's summarize. If you had to give the listener the take-home bullet points to scream out if they panic in the exam hall, what are they?
Okay, the panic list. 1. Neonates are not small adults. Their skull compliance and physiology are different. 2. ICP control is paramount. Your job is to maintain cerebral perfusion pressure. CPP equals MAP, ICP.
3.
3. RSI for all emergency neuro cases to protect the airway and prevent aspiration.
4.
4. Positioning is an art master. The shoulder roll for hydrocephalus, master prone positioning for MMC. Protect the eyes, protect the tube.
5.
5. Latex precautions are mandatory and non-negotiable for all neural tube defects. The pass-fail issue.
6.
6. Avoid glucose-containing fluids and hypertonic fluids. Use isotonic crystalloids.
And 7.
7. Normocapnia is the goal for ventilation. Hyperventilation is an emergency rescue maneuver only for impending herniation.
That is a solid life-saving list.
And always remember the link. They all lead back to the pressure in the box. If you can understand and control the pressure, you can save the brain.
I want to ask you for a model conclusion. You're writing the final paragraph of your 20-mark long answer. How do you sign off with style and confidence?
All right. You take a deep breath and you write something like this. In conclusion, the successful anesthetic management of this challenging pediatric triad requires a meticulous, proactive understanding of neonatal physiology and intracranial dynamics. The primary goal is neuroprotection, achieved through the diligent maintenance of cerebral perfusion pressure and the active prevention of secondary insults such as hypoxia, hypotension, and hyperglycemia. Successful long-term outcomes for these vulnerable patients depend not on one single action, but on a continuum of care encompassing early diagnosis, careful intraoperative technique, specifically regarding airway management, latex avoidance, and positioning and vigilant multidisciplinary postoperative monitoring for known complications like apnea or shunt dysfunction. Boom. Mic drop. That's a pass. That shows you see the big picture.
That is definitely a pass. To our listener preparing for the Gujarat University exams or any anesthesia exams anywhere, we really hope this deep dive has given you the structure and the confidence to tackle these critical questions.
Neuroanesthesia is famously described as hours of boredom punctuated by moments of terror. Your preparation is what allows you to handle those moments of terror with calm competence.
Good luck. Go ace that exam.
Good luck.
Thanks for listening to The Deep Dive.